Let's get it. This is Life's Essential Ingredients with Jeff and a Mike, where we hope to inform, inspire, and transform lives, one essential ingredient at a time. Welcome to the show. Pasho, listeners, it's been forever. We've been gone for about a month and a half. Maybe some of you thought that we were done, but we back. Baby, we back. We were not done. I was in the Canary Islands visiting my youngest daughter, and we are so excited to be back. Heard from a few of you like, hey, where are you? But we're here, and we have a great show. If you are new, welcome to the show. And this podcast is part of a nonprofit. The nonprofit is called C4 Leaders, and we're the only nonprofit to utilize the pizza making process to create space for our companions to be seen, heard, and loved. We also write children's books and use the most amazing handmade, hand-tossed sourdough pizza to bring out the best in each other. If you're interested in that work, check out pizzadays.org. So here we go, Pasha. We are season 4, still can't believe that, episode 5, with the amazing Dr. Reg Arthur Williams coming from Ypsilanti, Michigan. And I think I pronounced that. That's a fun name to say, Ypsilanti, Michigan, which is right next to Ann Arbor. Go Blue. First of all, to contact Dr. Reg, you can just reach out to rawill@umich.edu, and that's umich.edu. All right, Pasho, here we go. So about our guest, Dr. Reg Arthur Williams is a master teacher and professor emeritus at the School of Nursing and Psychiatry Medical School at the University of Michigan. Dr. Reg received his Bachelor of Science in Nursing in 1968 and then reported to active duty in the U.S. Navy, stationed at the Naval Hospitals in Pensacola, Florida, and St. Albans, New York. After active duty, he received his master's degree in Psychosocial Nursing from the University of Washington, Seattle in 1973, and then taught at the University of Washington School of Nursing and Psychosocial Nursing. He completed his PhD in higher education in 1980 and became chair of Psychiatric-Mental Health Nursing at University of Michigan, where he taught undergraduate, graduate, and doctoral students. He has conducted research on depression and was a principal investigator in research funded over a 15-year period by the Department of Defense Tri-Service Nursing Research Program to examine stress and depression among young men and women in military service. He has written 4 books and authored more than 80 journal publications. Dr. Reg, thanks for sharing your many gifts, for taking a leap way back when no one else was leaping into nursing as a male, and for dedicating your life to guiding people out of the depths of depression. Welcome to the show.
Thank you, Jeff. Thank you for that very touching introduction. I appreciate it.
It's one of the favorite parts for me to do the show, because sometimes I don't think people take a step back to just think about the body of work that they've done. And especially now as we start to get a little bit older, it's probably nice to just sit and say, you know what, I have done a few things with this gift that I've been given and made this world a little better. And so, yeah, we just love to honor the guests. And really this show, is an opportunity for you to just kind of share with the listeners your life and kind of what all the experiences that you've had, what you've learned from it, the essential ingredients that have been part of that. And so fun for Mike and I to do this. And listeners, again, we can't thank you enough. Somehow, Pasho, we're in 46 countries now, Pasho, 696 cities. What do you got to say about that, my Pasho?
Wow. Well, good thing you went to the Canary Islands there to visit Lou. Shout out to Lou. You're spreading the word. Good job.
We did have a couple people out there tune in. All right. So let's get to Dr. Reg. So we always start with a thought of the day. And we've been 100% on these. This is a one way, way, way far out there. It's going to be applicable to you, but I know I didn't hit it out of the park, but I know you can pull something to make it the streak continue to get going. So it is from Florence Nightingale. And I think I'm not going to give you my 2 cents on it. I want you to think about it. Here it is. The most important practical lesson that can be given to nurses is to teach them what to observe, how to observe, what symptoms indicate improvement, what the reverse, which are of importance, which are of none, which are the evidence of neglect, and of what kind of neglect. Why would I pick that one for you?
Wow. Well, it's very fitting because, when I think over my career and what I did throughout the research I did, along with the clinical practice I did, and the teaching, I did exactly what you just described, that observation. And I think in psych, that is so critical to observe the patient as to what you see and talk with the person about what's going on in their life. And that's pretty much captures how I approached every patient that I ever treated. And sort of the same thing in terms of how I taught as well as how I did research. And so it was really kind of neat in terms of that observation, paying attention to the minor details that people would just miss. And I can give you examples of stuff like that I did over my career, but let me just suffice to say that indeed that is very fitting to what I did throughout my life.
And real quick, tell the listeners who Florence Nightingale was.
Well, she was really the person that started nursing in so many ways. The cream and I can't even say it. The war that she was critical in terms of what she did and how she influenced the care of the soldiers that were injured in that war.
Yeah, for those of you, and I don't know if you know, Dr. Reg, but I was a nurse for 29 years.
I recall reading that about you, that so we share in our passion in terms of what we did throughout our career.
Definitely. We're going to get into that too. But yeah, Florence dictated so much of saving lives and what goes on even now today. And so, I had to honor her and thought you would appreciate her sentiment, especially with what you did in your role on the psychosocial aspect of, observing patients.
Mm-hmm.
So this show is called Life's Essential Ingredients. And this first one is just very broad, and you can take it any which way you want. But I like the listeners to kind of just get to know you a little bit. What was life like growing up?
Well, I grew up in a little tiny town in Utah, of all places, and it was a predominantly railroad and mining community. And as a kid, I remember telling my parents that I was never bored, because I wasn't. I was climbing the mountains all around the town, because we were surrounded by mountains in that little tiny town. And I had more fun with my friends going out, hiking. We found Indian drawings on the cliffs. I mean, it was an incredible childhood in many ways. And I was so fortunate to grow up there. And then I went to junior college and then eventually went to University of Utah, where I then got my bachelor's degree.
Any brothers or sisters growing up?
I have a younger sister. She was 3 years younger than me. She's gone now, but my brother, he was the youngest in the family. So I have a brother and a sister.
Okay. Nice. You still go back to Utah now, or is there family out that way? Or
there is, but a lot of my family, which in my hometown was predominantly my Italian side. So with the name of Williams, you would never think of me as Italian, but that's how I think of myself, as being Italian. So in my ripe old age, I've actually learned how to speak some Italian. Oh. And that's been, a labor of love too, to learn the language. Unfortunately, my mother was born in a family of 9 children. And most of them never learned Italian. They grew up in that generation where they said to my grandparents, well, speak English because you're now an American. And unfortunately, my mother never learned Italian, which she could have taught me. And that's so unfortunate, I wish. But nonetheless, even at my ripe old age, I'm still working at it. And I have a group that we meet every week and we practice Italian. And it's a blast.
That's awesome. So
That's
Mike can speak to that. Yeah.
I got to say, that's such a small world because Jeff was learning Italian. He met some people from Italy. He actually went to visit them, and he's coming along smoothly. Go ahead, Pasha. Give him a little bit of your Italian.
Piacere. You know piacere?
Piacere, sì,
Yeah.
sì, piacere. Yeah, pleasure to meet you.
Yeah. Mi chiamo Jeff. There you go, Pasho. I'm throwing down my Italiano on him. We have to be able to speak that Italiano if we're going to make it a pizza. Yeah.
It's
And that's
amazing
true.
how many.
So, Jeff, you and I can make a good pizza. Let me tell you, I can make a great pizza.
Oh, yeah. Well, I thought that's why we got you on the show, was just to do a little demo. So maybe next time we'll have you come on, and that's what we do. We just make that good sourdough, homemade hand-tossed pizza.
There you go. I'm all for it.
Well, good for you. What would you, for any listeners out there, let's just change it up real quick. Anybody that's out there that, I don't know how old you are, but you are a few years older than us and probably in your 70s. You look amazing. But what advice would you give to somebody that's out there? It's like, man, I would love to learn something, but I just feel like I'm too old to try and put myself through that. And that's amazing that you're doing that with your Italian.
Well, Jeff, I think one of the things that has really been something that I have had as part of my life is the desire to learn something new. And I've been driven by that, I just enjoy learning new things. So I've exposed myself to any number of things that I learned. So, like, for example, when I retired from University of Michigan as an educator, I ended up taking video production courses at the community college that's right near my house, and basically completed a associate degree in video production. Why? Because I really wanted to learn how to edit videos and make videos. And I thoroughly enjoyed it. This is the craziness in terms of what I did. I even took the courses for credit. So that meant I had to do the tests. And I even told the instructors, I said, listen, I stopped taking tests many, many years ago. I just give tests. I don't take them. And there I was back as a student taking tests. Oh, that was humbling. That was a humbling experience, but it was fun. I had more fun in that. And I worked with the kids that were, taking the courses at the community college. And we just got along famously, and it was so much fun. And so, yeah, that's me, always learning something new. And Italian is just one of many things that I've learned over my years of hobbies that I have.
That's awesome. That's awesome. So that's a good segue into kind of what are your life's essential ingredients. So obviously the desire to learn, a lifelong learner would be an example of one of your ingredients. And I want to ask you this in a little different way. It's going to be a part A and part B. Would you say your ingredients 20 years ago were different than they are now? And if so, what? And if not, how come?
That's an interesting question. My first reaction to the question is that I'm not sure it's that different. I mean, I've sort of been like this pretty much my entire life. I always, when I was a nursing student, as an example, going back way when, I took advantage of every learning opportunity I could do. So if there was an autopsy going on, I said, sign me up. I'll be there. I was always learning a new procedure. If I needed to watch a thoracentesis, I did that. I mean, I watched brain surgery. I mean, I took advantage of anything I could learn and get my hands on to just expand my knowledge base. And that's what I did. I'd say that's pretty much continued throughout the rest of my life, always wanting to learn something new. So, for example, when I retired in 2012 as teaching at the University of Michigan, I ended up learning how to do gem faceting. So gemstone faceting is what I learned. And my wife was convinced I don't have the patience for it. She said, "Oh, you probably not going to do that much, et cetera." Well, it's been a passion. So I now am the editor of the newsletter that goes out to the guild in the Midwest. So it's called the Midwest Facetors Guild. So there I go, being now an editor. And so this is always something. I always got something going on. That's just me. And so I'd say that's been the fun part of my life when I think over all these years. The other thing that I would say that I always told my students is never say never. And what I meant by that is when I finished my bachelor's degree, I thought that's it. I was one of the first in the family that had a baccalaureate degree. And so I figured, that's where I'm stopping. I'm just going to go out there and work, blah, blah, blah. Well, I got on active duty. I was longing. I would have given my eye teeth for an intellectual discussion about anything. And I started realizing I need to go to graduate school. So while I was on active duty, that's when I made the decision that I was going to go to graduate school. So I got accepted at University of Washington in Seattle, drove clear across country with Brian would have been he would have been 7 months old in the back of the car. Oh, that was fun. I can tell you, going clear across country with a 7-month-old is not what you'd call fun, but we made it. And so got to Washington and started my master's degree. And within a very short time period, I realized that I really wanted to go on for my doctorate, because I think I realized that I really wanted to teach and do research. And so sure enough, I taught at University of Washington for about 4 years before I then was admitted into the higher education program at University of Washington, and loved it and worked my tail off to get that done in post haste, and then took the job as chair of Psych-Mental Health Nursing at University of Michigan. Thought I'd be at University of Michigan for 5 years. Return to the West, which was my plan. Well, you can see how some plans go. That didn't work. But nonetheless, I've been here at University of Michigan, but in Michigan since 1980 is when I first came to Michigan. So that kind of gives you a little bit of a roundabout answer to your question.
Wow. Yeah, just love hearing that. And we're going to get into the male nursing. I got to share some of my stuff at that time, but I do want to get into your expertise, and listeners, it's funny to be a nurse, an active nurse, you have to take continuing education classes and you have to take 30 hours to keep your license active. And so I'm not a practicing nurse. I'm actually retired. But who knows if I end up doing some little work on the side, and I'm not ready to let my license just go. So I took a class. I'll give Elite Healthcare a little kind of shout out. And the in-person teaching it was Dr. Reg. It was a long course, 28 hours. But the content was incredible. And I just appreciate all the hard work and dedication that you put into that. Nothing against, but a lot of those courses is just not so good sometimes. And so much good information in there. And I think that was a big reason for me wanting to get you on the show, because depression is just affecting so many people.
Absolutely.
And so I want you to kind of just get into that a little bit. And the first thing, I don't know if you'll, know the actual numbers. I'm guessing that you will. But if we just were to look at depression from a historical kind of standpoint, not way back, but just what are the trends of depression for people to kind of take notice of?
Well, as you mentioned, depression is an illness that affects a lot of people, and it really does. And it seems that it keeps increasing. And so younger people are getting either anxiety or depression at an early age, oftentimes. It used to be thought that depression you wouldn't see until into the 20s, and that's not true. I think you can have people, and I did have patients. I had one young man who told me that he could never remember a time that he wasn't experiencing depression. And so he thought he actually was depressed when he was 8 years old. So it can start very, very young. But typically, what I see in the patients that I treated was that very often when they were in either high school or college, the stressors that were on them became immense enough, or they had a breakup of relationship or something like that, that really sent them into a downward spiral. And they would think that they could just pull themselves out of it. And with clinical depression, you can't. You can't just think yourself out of that depressed mood, because it's profound. It really encompasses your life. And the person feels very down. That's one of the criteria for depression is a depressed mood. And then the other that is often accompanying is the lack of interest. They lose interest. And then they start isolating. They start not talking to their friends. They don't return phone calls. Oh, I can't tell you how many patients that I would encounter that hadn't called a friend, hadn't called their family, and they were depressed. And that was just so common that I would see. And sometimes my intervention with them would actually be to have them call a family member, a friend, while they were with me in the office. So I'd be there to support them to make that phone call. And it was amazing that when they'd reach out, of how that started lifting the depression. Of course, along with the medication that I may have prescribed for them because of the need, much like I would explain to patients that if you had diabetes, you might need insulin. You can't just say, well, I'm going to stop insulin. I don't need that anymore. It's the same thing with treatment of depression. So there are patients that sometimes can stop their med after they get the depression lifted and they're doing well. And what I often did with patients was say to them, I'd like you to really stay on this medication for at least a year to really correct those neural pathways in your brain. And so then after a year, if life is not stressing you out, you don't have any major upsets in your life, then we can talk about whether you want to try coming off the med or not. And sometimes patients would, sometimes they would say to me, I think I'm not ready yet. And it might be a year or two later that they would say, I think I'd like to try it. Sometimes they'd be very successful. Sometimes they didn't. Sometimes I'd end up putting them back. But what I would go over with them is what I often described as their prodromal symptoms. Those symptoms that were the most early on, that told them they were heading for another depression, but they didn't recognize it at the time. And it could be as simple as they're not sleeping right, or they're feeling down and it's not getting better, or they're having difficulty concentrating. Those were often the prodromal symptom that was an indication that they were actually going into a depressive episode, but they didn't recognize it. So it was talking with them to recognize it up front so that if they started developing depressive symptoms, we could get them back on the medication and get them treated so that they didn't go into another depressive episode. Because like I would explain to them, it's like you're getting a punch to your brain with every depressive episode you encounter. That takes its toll on the brain. And so, what we want to do is prevent that. And I had a lot of success with the people that I treated because it was fun to just help them to understand, giving them strategies that worked. Simple, not complex. They didn't have to contemplate their navel. They literally I would work with them around simple steps that they could take to correct those depressive symptoms that they were experiencing. And of course, I came from a more cognitive behavioral perspective because of the fact that it's the distorted thinking. And I can give you plenty of examples of distorted thinking that patients exhibit. But that is what you're really correcting and helping the patient to deal with, coming up with strategies to correct those distorted thinking that was going on in their brain.
Mm. You said so much right there, and not to be able to unpack it all, but I definitely want the listeners to be able to kind of self-evaluate. And it's crazy how these thoughts of the days, I use them all the time in just about everything that I do. But it's not just nurses, to teach them what to observe, how to observe, what symptoms indicate, good or bad. That's what we need to be doing each and every day of our life. Mm-hmm. And you went over quite a few of them. But if there's somebody listening that's like, is he talking about me? In a simplified way, can you go over a clinical depression versus someone feeling down? Because when you talked about, prodromal symptoms, people not sleeping, not being able to concentrate, just, their thoughts kind of being all over the place a little bit. I don't want to mix in and get us too far off track here, but that's a good chunk of people. And I think there's so many other potential, even just technology kind of interfering with that and causing that of not having good sleep hygiene, and being on your devices before you go in, which is just your brain's just going too much. So how can we help that one listener that's out there who's like, man, do I need to go in and seek help? Because he might be talking about some of the symptoms that I have.
Mm-hmm. Well, indeed. And I think what I always encourage people to do is if they are experiencing the typical symptoms of depression, and every person is a little different in terms of what they might experience. But when they are showing signs of depression with the depressed mood and lack of interest, those are two real keys to being diagnosed with major depressive disorder. But then there's other things, the lack of sleep or oversleeping, undereating or overeating, difficulty with concentration, feeling guilty about what they're experiencing. One of the things that depression does, by its mere nature of how it works in the brain, is makes the person feel weak. They're not, but that's how they feel. And so they think, I'm just being weak here. I'll just be able to pull myself out of it. And like I said, with clinical depression, you don't. And of course, one of the most concerning aspects of depression is suicide thoughts. If they are actually thinking about, I think I would be better off dead. My family will be better off with me dead. Absolutely not. And one of the things that I would always do on any evaluation that I did of a patient is we would talk about any thoughts that they had about suicide. And if they said to me, yeah, I've thought of it. And, I thought maybe my family would be better off. So I'd stop right there and say, I want to explain something to you that's very important that you hear. And that is let me assure you, your family is never, ever better off with you dead. They will live with that for the rest of their life. You're gone, but they live with it forever. Is that something you really want to leave your family? And I can't tell you how many times, Jeff, that I had patients say to me, I never thought of it that way. And it sort of like a light bulb moment came on for them to recognize that that suicidal thought was literally dealing with their pain, and they weren't thinking about what pain that would inflict on the people they care about. And that would oftentimes really help for me to really make an agreement with them that, look, if you have any increase in these thoughts, I want you to see me immediately, or I want you to go to the psych ER at University Hospital, because this is no different than if you were on the road bleeding, that someone would come rush and take you to the hospital. It's no different. This is an illness, not a weakness. It is a physiological illness, just like any other physiological illness. It is not any different. And those kinds of things is what really would impact a patient to seek help and to recognize their own symptoms.
And speaking of, so say there's a listener out there say, that might be, my mom, my dad, my brother, my sister that Dr. Reg is talking about. But then they show signs where they're kind of really active and seem focused and hyper focused, and maybe get into a little bit of bipolar, and educate the listeners on maybe what that looks like and what that is, and how sometimes those go hand in hand.
Yes. Well, bipolar illness is certainly an illness that has some very profound outcomes in terms of the person. Typically, bipolar illness sort of starts demonstrating itself usually late teens, early 20s is not uncommon to see bipolar illness. One of the ways that sometimes they can present themselves as depressed, because as the term itself suggests, that they can have a manic phase and they can have a depressive phase. And they may be, when they first present, in a depressive phase. If they're put on a antidepressant, specifically a selective serotonin reuptake inhibitor, that can actually, if they are truly bipolar, can tip them over into a manic phase. And that sometimes is a way you can diagnose bipolar illness, is just by the mere fact that they were started an antidepressant and then all of a sudden they're spinning like mad. And that is one way to do it. But it's the aspect of bipolar illness is either that very depressed mood, or where they may level out sort of normal, and then all of a sudden they go into what is a hypomanic phase, and then that can eventually end up in a manic phase, where they are speeding, they're talking fast, they're irritable, all of the things that go along with it. Most patients that I talked with that were bipolar would love to stay in that, not the manic phase, but basically have that hypomania where, man, they can accomplish incredible things. The trouble is it doesn't stay there. And there's where they get into trouble. So they can go and overspend. They can become promiscuous. There's any number of behaviors that they can exhibit that really get them into trouble. They can start drinking excessively, to try to control. They self-medicate in that sense, using drugs or alcohol. I mean, it just, the gamut goes on in terms of what it is. I think whenever you're dealing with a family member that you have worry about, I always encourage patients to say to their family member, look, I'm really worried about you. How about if I go with you to get this evaluated? Support them in doing it. Threatening doesn't do anything. telling them that, you're crazy, that does nothing. And so it is more important that they talk with a person about what they are concerned about that they see, and see if they can tap into that part of them that's willing to at least hear them. And if they have, they may be able to get this person in for evaluation. And that's the key, is get this evaluated.
Yeah, no, thanks for all those great tips. And probably the last thing, then we'll move on from this subject matter, but I know it's tricky. And obviously me as a nurse, I don't prescribe any medication, and psych was not my expertise. I was a trauma ICU nurse.
Uh-huh.
And my question is, if you can give some insight, and this is a tricky question, but so many times with mental challenges that might need some medication, the way medications are created, they're not created equally, that's for sure, based upon your genetics. And I don't know if people are all the way aware, and I still think we're a little bit behind, but there's some companies out there that are doing it, that specifically for psych meds, like Insight. I don't know if you're familiar with that company that can kind of give patients guidance on medications that work based on their genetic profile. And I just want to make sure that the listeners are aware that there are companies out there that hopefully your insurance company realizes. And I hope eventually we can get there just as a society where that's just the norm. But yeah, share your expertise on that.
Indeed, I actually made that part of my standard practice in terms of treating patients. So I would do the genetic test. It was a GeneSight was the company that did it. And I could do a swab of the person's mouth, just their cheek, inside their mouth, and send it to the company. I would often see patients on a Friday, so I would take it to the post office, or I shouldn't say post office, because they did FedEx, drop it off at the FedEx office, and literally I'd have the report back on that following Tuesday. And so now they've got it so that the patient can actually have the kit sent to them to just do the mouth swab to then send to the company. It's marvelous because of the mere fact is that it puts these different psychiatric meds into three categories: green zone, yellow zone, and red zone. The green zone are the meds that are most likely to be metabolized by the patient, where they will not have a lot of side effects. The yellow zone are meds that may have a little more side effects for the person, but the red zone are the ones that are more likely to cause the patient more difficulty. The other thing that the GeneSight test did is it would actually make it possible to determine if a patient was a rapid metabolizer or a slow metabolizer. If they were a rapid metabolizer, it meant that it was going to take more med to have an effect. If they were a slow metabolizer, if you put them on a normal dose, they would have awful side effects to the point where they'd say, I can't tolerate this. I can't take this. And that was valuable because I had several patients that were slow metabolizers, and I literally put them on the lowest possible dose to have, and then a week later they came back and said, my goodness, I feel better. And they had experience where they were put on a psych med and they were a slow metabolizer, and they got all kinds of awful side effects, and it was just too uncomfortable. So in any event, that is a test that I used as standard practice, and it really was marvelous. Now, it's not a panacea because it still doesn't say, okay, this is the best med to use. It doesn't provide you that, but it certainly gives you the opportunity to narrow what you're going to prescribe rather than shooting from the hip, because that's what you had to do before.
Yeah. Yeah. I'm really hopeful that eventually all meds can be geared that way, because it's just,
Absolutely.
such a big problem. And so many people need that help and more tailored help. And it seems like that's the way the world is moving. So let's make sure the medical side of things can keep up with everything else that's going that way. So yeah, thank you for taking such great care of your patients and for providing that. Let's change it up here just a little bit.
Okay.
I loved in your introduction, you're a master teacher. So let's get into Pasho is thinking about teaching. He's thinking about switching over and getting out there. What advice would you have for a young person or anybody that's listening? Because I think learning has changed so much, especially with COVID. And I don't know if we've caught up on the teaching end of how everybody is processing information now, and how they are actually learning or not learning. What couple of tips would you give to somebody that is working with people that are teaching?
Well, I had so much fun in teaching, and that I've often said that I had the best of all worlds. I taught, I did research, and I did clinical practice, none of which I would have wanted to do solely. I did all three of them, and it was so rewarding. That is one, to have that diversity that makes it enjoyable. And teaching is fun. You really are impacting students in a profound way. And so even in retirement, I do a guest lecture of all things suicide for the undergraduate students at University of Michigan. And I've been doing that for, oh, good Lord, quite a long time. A number of years since I retired, I've been doing this same lecture. But I have more fun doing it, and I get those students right in the palm of my hand, and I've got them in terms of their learning. So I think one of the things of teaching, there's a couple strategies. One is I'm always updating what I teach. So every time I do this lecture, it is not the same lecture that I did the time before, because I've looked at the research that's been done on suicide. I add that, take away something that's really not so important. In short, I'm always updating. That's one. The other is doing a presentation that captures the student's interest. And I've built a skill to be able to do that I pull them in to my sort of severe, and I engage them. I ask a lot of questions and have them answer, and then help them to really know what their true answer is, so that they get it correct. That kind of thing is what is, I think, so important. The worst thing to do as a teacher is stand behind a podium and just go from slide to slide to slide. That is so bloody boring that people just say, oh my, just stop, I can't take it. And so I think it's important to be yourself, when you teach. And I use a lot of humor. I've done that in all my teaching. And I also did a lot of humor with my patients that I treated for depression. Humor, the ability to be able to laugh, I think is a curative factor, both in teaching and clinical work. It truly is. So I would joke with my patients. I'd tell them all kinds of things, and we'd have fun in doing that. And I think, one, it made me more real to them, and two, it engaged them. They were with me in terms of what they were learning, the strategies that I was giving them, and incorporating them and giving them a chance. With the patients, I would say, look, I'm an educator. I'm going to give you homework. So I would give them homework to take for between the week that I saw them to the next week, and have them practice something that I wanted them to work on and come back and report on it. And they would do that. And boy, it was powerful, of that teaching that I did. So both in terms of teaching students as well as teaching patients, it was no different. It's teaching. And that's the joy of literally educating people.
I love it. Great tips. And speaking of education, I see a few books. Listeners, if you just listen in, you can't see what Mike and I see, but this is shown on YouTube. And if you're a YouTuber, yeah, Dr. Reg has got lots of books behind him. I don't know if it's a backdrop or if it's legitimate, but either which way, any books that you recommend or just that you're reading now since you like to learn, and it doesn't have to be about the stuff we're talking about, just any good book that you think would be helpful for the listener to read.
Oh my. Well, just to mention to you, Jeff, those books that you see behind me, I've read every one. and if you believe that, well, I could make up another story. So, what book would I recommend? Oh, gee. I just finished a book that I actually downloaded for my Kindle, and now you're going to ask me the title, and can I remember the title? And I don't. But it was a fascinating book about what happened in Ukraine of this couple that literally had to leave Ukraine just before World War II. And the venture that they went on, adventure, and that's a misnomer to even say adventure. It was horrible of what they experienced. But I mean, that book was one that you just couldn't put down. And unfortunately, this is my problem, that I'll read a book and then I forget the title. And this is an example of one. I just don't remember the title.
I'm the same way.
I'd have to look it up. But,
to read.
But in any event,
Mike
I'm sorry.
More like an elephant, and he remembers stuff a lot better. But yeah, we both love to read, and I'm the same way. I won't remember the exact titles of the books, but no, that sounds like a good one. And I think we're getting ready. I think it's been a great episode. I think I would love to ask you our last question, and it's really a quote from John Alston. It's the only thing you take with you when you're gone is what you leave behind. And that's fast forward, 20 years for you, and you're on your deathbed, and you've lived a great life, and you've served all these different people who have been blessed to be in your presence, and you've taught and worked with, and patients that you've provided great care for. What is it that you want to know that your life meant, and what you leave behind with the people that have been in it?
Well, the work that I did and the research that I did, the writing that I did was leaving a legacy of much of what I tried to contribute to the welfare of people, whether it be students that I worked with or patients that I helped. The love of my family and how much I value, especially that Italian side of my family, and how much we care for each other, and all the pasta dishes that I ate throughout my entire life. My mother was a fabulous cook, and I've carried on her legacy. That's a hobby for me to cook. So I do a lot of Italian dishes that I prepare, and my wife has benefited. And then with, of course, the Jim Stone faceting, she drips in jewels. So I remind her on a regular basis of how lucky a woman she is. And my daughter the same. So they do get that from me all the time. So yeah, leaving that legacy I think was important to me. That's why I wrote. That's why I contributed to the science, to leave that. So that's my hope. That's what I leave when I'm no longer on this earth.
Beautiful, beautiful. Pasho, share your thoughts and get us out.
Wow, man, that was fun. Just sit back and listen. And I always say, Dr. Reg, when someone can break down something complicated like what you're dealing with, break it down to me in simple terms, it just shows that what a master you are of that art form. So I appreciate that, breaking it down to me.
Thank you.
And on a side note, I'm sitting here, and the similarities between you and my Pasho Jeff here is absolutely unbelievable. And when you're talking about leaving a legacy and all that, I don't know if you saw his face just lighten up. because it's like he was saying almost exact same thing, leaving that legacy and just how powerful family is for both of you. And also the way you became a nurse back when it was a norm for a male to be a nurse. Jeff, when we were at the University of San Francisco, might have been the only male nurse in the whole program. And
I was the same, Jeff. I
wow,
was exactly the same.
it's like I'm looking at mirror images right here. So thank you for all that. I appreciate it. Thank you for being on the show, and thank you for all your work.
Well, thank you so much for having me. I really feel honored to be able to talk about this, and thank you for the opportunity to share a little bit of my life.
It's been great. Again, listeners, season 4, episode 5, Dr. Reg Arthur Williams from Pasho. You say, do you remember where he's from?
Of course, Michigan.
All right, Ypsilanti. I just want to say that one more time. And if you want to reach out to him, it's rawillt.umich.edu. And listeners, this is how we do it. Boom, baby. That just happened. We out.